Good afternoon, and thanks for joining us for today's Healthline 3. I'm your host, Courtney Butts, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines soon, but as a reminder, please make sure you're in a quiet room when you call with your TV turned all the way down so we can hear your question. That number to call is 318-219-4569. That number will be right there on your screen. Today's topic is all about SI joint dysfunction and pain and cervical disc replacement. And joining me to talk in the studio today about this is Dr. Matthew Hefner. Thanks for joining me.
Yeah, thank you for having me.
Yeah, so tell me, you're a neurosurgeon.
Right.
Which sounds really cool. So tell me what you do exactly.
So as a neurosurgeon, we're trained to treat disorders of the nervous system that are treated with surgery. So most people think about brain surgery, and that's definitely a part of it, brain tumors, things like that. But a big part of it too is treating neck and back conditions. That's actually most common. So ranges from treating neck pain, disc herniations in the neck, low back pain, sciatica, various conditions.
Okay, yeah, and so a lot of people struggle with this type of stuff,
Extremely
right?
common.
Yeah. Yeah, and yeah, I feel like SI joint, like this is something that a lot of people struggle with as well, dysfunction of that or pain with that, or?
Yeah, it's not as common as other things that I see, but it's very easy to look over because not a lot of people think about it. It's not always talked about. They say that of people that come in to see a provider across the U.S., like 85% of people do have low back pain, but of those people, probably 15% are actually SI or sacroiliac joint dysfunction, and it gets overlooked because initially they're treated a lot of the same ways, but long term they're very different entities and treated differently.
Right, and so we're going to talk about neck issues as well, and I feel like that's a pretty common thing.
Exactly.
From, you know, this is what we're doing all day long, looking at our phone,
Right.
looking at our computers.
The text neck. Yeah.
Text neck,
Yeah,
I like that.
it's a thing.
Okay, so, and there's pain associated with that usually, or?
Yeah, most commonly people will say, you know, I have neck pain, worse throughout the day, you know, usually in the back of the neck, and that a lot of times is muscular. That's very common. But usually what gets people to come see me is when they start having more debilitating issues like, you know, nerve pain shooting down into the arm, tingling, weakness, dropping things. That's when things, you know, usually require more of a workup and treatment.
More of that like nerve
Exactly.
pain.
Yeah,
Okay.
nerve pain.
Not the muscle pain. Okay, gotcha. What exactly is so sacroiliac, right? Saying that right? Sacroiliac joint dysfunction. So can you tell me a little bit more about that?
Yeah, exactly. So sacroiliac joint, or we just refer to it as SI joint, is the joint that connects the lower back into the pelvis.
Yeah,
And
let's see this model.
What I have here that makes it easier to understand is if this is a spine of the lower back or the lumbar spine, the white is bone, the yellow are nerves, and this out here is the hip bone. And then this would be the thigh bone or the femur. So where the hip joins into the lower back, that's the SI joint right here.
Gotcha.
And practically speaking, where most people feel that at, they'll say it's about where the belt line or the pants line would sit, just off to one side. And people that have SI joint pain, they're going to have pain in that area. A lot of times it's worse to walk and put pressure on that leg. It's worse to sit down on that side. Like men, if they have a wallet, they'll often will put it on the other side. And usually they'll say the pain wraps around the front into the groin and down into the leg.
Gotcha. What about like stretching forward? Do you think that pain is exacerbated usually when moving?
Yeah, usually the kind of movements that make that worse are things like rotating your hip outward or, you know, taking a stretched leg and turning it out. So people that, you know, it's very rare that I get somebody that comes to see me, they're like, oh, you know, I think I have SI joint dysfunction. They're always like, I have low back pain, or my doctor sent me for low back pain. And usually, you know, by doing a good physical examination, really checking range of motion, checking multiple things, it kind of leads me to say, you know, I think this may be more of an SI joint issue. And so, you know, always explain that to patients what it is. Regardless if it's lower back or SI joint, the treatment is almost always the same up front though. Anti-inflammatories, muscle relaxers, sometimes nerve medications, and physical therapy do a lot of good for probably 80 to 90% of people initially.
And that's, the first line that you'll try, and then if it worsens, then you would try surgery?
Yes, so if we do physical therapy, medications, and nothing's really very effective, then usually the next step is I may get a CT or an MRI of the back just to rule out anything else surprising. And to really make the diagnosis, the way we do it is I will refer to a colleague who usually will do an injection into the joint. And that injection is not meant to last always, but if that helps, then that tells me I'm pretty sure it's your SI joint, and then we can get off into treatment options of it.
Gotcha. So take me through that surgery process. How does that work?
So the surgery is a fusion, and most people are like, oh my gosh, I don't want a fusion, I don't want to limit range of motion, which I completely understand. However, the SI joint is not meant to move. It's meant to be two bones brought together, and when you get arthritis in that joint, it starts to move and create friction. So the point of the fusion is to put screws or implants across the joint to hold it stable. And so I do these robotically and minimally invasively. And so put the patient on their stomach, they're asleep, make an incision about this long over where the SI joint is, and using the robot to keep blood loss, tissue disruption to a minimum, I put anywhere from 2 to 3 screws across the joint.
Gotcha.
And what that'll do is that'll help retighten the joint and hold it together. And then over time, bone will grow across it. And that has a high success rate. But again, it goes back to making an accurate diagnosis. That's why for me personally, it's a bit of a prolonged workup. Nobody comes to me and gets signed up for a procedure right away. We have to do the therapy, we have to do the injections. And then I think when you do that, then the success rate is very high because you're selective in who gets that sort of procedure.
Yeah, that's really good. Okay, so we have Jerry on the line. Jerry, thanks for joining us, and what's your question?
Okay, my question is like, okay, I had a pain in my joints of my knees. Okay, and when I walk, the pain goes all the way up to my head, and it makes me dizzy, and it hurts. It just like it pulls your whole body together. And every step, it's like you could just pass out.
And so the pain starts in your knee?
Starts in your knees. It be there every day. It's been there now. And like if I walk anywhere it's like inclined plane, it gets worse.
Okay. So if it starts in the knee and it's working its way up, it could be a knee condition. I don't know if you've ever had anybody look into the knee to see about getting that looked at, but that could be a part of it as well. But certainly, if you feel like it's in your back or things, a good place to start would be your primary care doctor. Let them kind of evaluate you up front. And but that could be a whole variety of things for sure.
Well, all I know is it hurt.
Yes, sir.
All right, thanks, Jerry, for your question. If you're just joining us and you have a question for our doctor, we have Dr. Hefner here, neurosurgeon with Willis Knighton Precision Neurosurgery. Oh, I think we do have someone on the line. Did you say Tina? Tina, thanks for joining us. What's your question?
Yes, my doctor referred me. I'm actually coming to my appointment tomorrow, but my question is, I've been having compression fractures in my back, and somebody had mentioned to me about the bone cement. Is that an option for me?
Yes, yeah, that's probably what they're referring to as a kyphoplasty or vertebroplasty. I do a lot of those as well. They're very good for fractures. It's kind of the same thing as like with anything else. Most people don't need that. They usually respond well to giving it time, wearing a brace. But if pain is refractory to that, go in with just a needle, put you to sleep, and just balloon the fracture open and put cement into it.
Okay.
Yeah. It's a great procedure,
Thank you.
but definitely need to evaluate and make sure that you're a good candidate for it.
Okay.
Thank you, Tina, for your
you.
question.
Thank you.
Yeah, so brings me to a good point. We mentioned off air that if someone was wanting to, come and see you for an evaluation, that needs to happen with a physician referral, correct?
Yes, typically so. Patients usually get to me through their regular doctor. If they come to the ER with issues, they refer. Usually, for most of these issues, it started with the primary care doctor or your family doctor. And if they need you to come see me, with a referral, definitely will accommodate.
Awesome. Yeah, so that process, they refer to you, and then, once they're referred, then your office would reach out to them to get them scheduled.
Exactly.
Okay, pretty easy.
Yep.
All right, cool. Okay, so we've talked about the SI joint dysfunction. And we've talked about the signs and the symptoms and the treatments and all of that, but how does this come about usually?
Wear and tear.
Okay,
Yeah,
normal wear and tear.
arthritis, just degeneration. It's not usually something that anybody did or could have done to prevent it. It just happens with as we get older, our joints start to wear down a little bit.
Gotcha. Yeah, I know. So much to look forward to as we age, right? Okay, and so the pain that's associated with it, is it usually a pretty significant amount of pain?
It's pretty significant for people that get to the point of seeing me. Usually most people, they've already been on medications, they've given this time. And people will know, like, it's usually like they'll point, I'd say take one finger and point to where it hurts, and usually they'll take their finger and put it right on the joint, and I'll mash into it, and if they don't like it, and so I'm like, that's your SI joint. And then we kind of, go down that whole workup of, getting an injection, getting some imaging studies, and then if I feel like that's it, and, we have that conversation about if surgery's right for them or not, and if so, then we get it taken care of, and people tend to do well.
Yeah. So have you seen, how have you seen SI joint surgery maybe advance in the last couple of years?
I think it's advanced. The technique's about the same, but robotics has really taken what used to be an open procedure that was more morbid and really turned it into a streamlined, minimally invasive procedure. And that's what I do in my practice. Is people come in. They have one small incision, and through that small incision, I'm able to get in the hardware and the implants. And, after surgery, they go to day surgery, they wake up. I get them with therapy, moving around, walking, with a crutch or an assistive device at first. And they're home.
Yeah.
And they're sore, but people will usually say it's a different kind of pain.
Okay.
And, yeah.
Yeah, and then, once you're recovered, then the pain usually will go away.
Yeah, I tell people, nothing's going to be perfect. You're just being realistic and honest. You're going to have some aches and pains, but again, I think, comes down to patient selection and picking the right patients, and they do well.
Yeah, okay. So you mentioned the hardware. So what do you put in, in the joint?
So
is it kind of like hip replacement a little bit?
In a sense, so we call it screws. I mean, it looks like a screw. There's different types. The one that I implant is made of a mixture of titanium and an advanced like polyethylene alloy that's threaded. And so I create the hole where the screw goes across the joint and then place 2 to 3 screws. And it's designed that once it hits that outer surface and tightens up, it kind of holds things together.
And that's all through a robot?
Yeah.
Wow.
So with the robot, it's still me physically, like I'm deciding everything, I'm physically putting in the screws. The robot helps me to do as much as possible through a small incision, through like everything being as precise as possible.
Very cool. Okay, cool. So we have Don on the line. Don, thanks for joining us, and what's your question?
Yes, look here, my question, it is, how can I get a chance to come in to see the doctor?
Yeah, sure. What are you wanting to come in for?
Look here, doc. I done had my L3, my L4, and my L5 done in my back. So I took an MRI. My doctor told me, did my L2 messing up, man. I got so much pain. I got too much pain.
I'm sorry to hear that. I'd be more than happy to see you. Just tell your doctor who ordered the MRI or your primary care doctor that you want to come see me, and once you do that, you can give us a call, and we'll definitely be more than happy to see you.
Right. So tell me, what's your name?
My name is Matt Hefner, Hefner.
Matt.
Yeah, it's right there on your screen.
Matt. Okay. Oh, you get hold on. 1 second.
Yeah, you can snap a pic real quick.
Yep.
I'm sorry. I'm trying to write right now.
That's okay.
Oh, that's okay.
That's okay. Hefner.
Okay. I don't know what the hold on. Hefner. Hefner. Okay. So where you located? Willis Knight?
I'm at Willis Knight and Bossier.
Willis Knight and Bossier. Okay.
Yep.
Okay. Look, I do go see my primary doctor. So what's the necessary thing that I need to do? Do I need to get a referral to come see you?
Yes, sir. You just tell your primary care doctor that you want to come see me, and I'll be more than happy to get you in. They'll know exactly what to do.
I will do that.
Okay. Thank you for calling.
Thank you.
All right, thanks, Don. And if you have a question and you're just joining us, we have Dr. Matthew Henry, or Matt Henry here with, Hefner, sorry, Dr. Matt Hefner with Willis Knight and Precision Neurosurgery. And I think we have another caller. What was the name again? Jessica. Jessica, thanks for joining us. What's your question?
Yes, ma'am. Okay, so on my toes and on the bottom of my feet, they stay numb and stuff a lot. And I was wondering what is causing that.
How long's that been going on for?
For quite a few years.
Any other medical conditions?
I got like high blood pressure, and that's it.
Okay. Any diabetes?
No.
No. Well, it just depends. I mean, do you have any numbness higher up in your leg? Any back pain? Or is it just to the feet and toes?
It's just to the feet and toes.
So usually numbness, tingling, usually indicates something more like nerve irritation, nerve damage. It could really be from a whole host of issues. It could come from the back. It could come from nerve irritation in the foot, something like a neuropathy. Very broad there. I definitely would get that checked out. Starting with your primary doctor would be a good place to run some basic labs and look into things.
Okay.
Yeah.
All
Thank
right.
you.
Yeah, thanks, Jessica, for your question. And we love your questions. Just give us a call at 318-219-4569. And I want to get to some of my questions. So tell me a little bit more. We talked a lot about the SI joint.
Mm-hmm.
So we talked about earlier, in the show that neck issues is something that you also treat as well.
That's right.
Yeah.
So neck issues is, along with back pain, one of the most common things I see and treat. So many people, like you had alluded to, looking down all the time in our society on computers, cell phones, tablets, they come in with neck pain. Usually it's muscular, and again, physical therapy is a cornerstone in my practice. That does a lot of good initially for things like that. But when people start saying, it's not just my neck, I also get numbness, burning, weakness in the arms, and then that's where we start looking at, do we need an MRI? Mm-hmm. And so a lot of times people will come to me with a disc herniation. The disc is the cushion between the bones, and sometimes with deterioration or arthritis, that can wear down and put pressure into the nerves.
Okay, and so that would be,
That would be on our model here. That would be like if the white is bone again, the disc is this little cushion in between.
Okay.
And so the spinal cord and the nerves are behind that. Mm-hmm. So when that wears down and bulges, it will push into the spinal cord, push into the nerves.
Sounds very painful.
It can be.
Yeah, okay. And so so you do like an artificial disc treatment for something like that?
Sometimes.
Okay.
Sometimes. It's an option. Again, I'm very selective in who gets that to make sure that whoever does well. Just like when we talked about SI joint, the reality is most people with disc protrusions, disc bulging, unless something severe like spinal cord compression with things to worry about are weakness, dropping things, numbness, balance issues. Outside of that, I say, look, let's just kind of slow down. We'll do some physical therapy, put you on some medications, and usually that takes care of most of it. And then if not, we can talk about the option of, do we do injections or do we do surgery? And then specifically with my practice, when I'm looking at doing surgery on somebody, if you're looking at addressing a disc herniation, the two most common is something called an ACDF, which is an anterior cervical discectomy and fusion. And I know that's a mouthful.
Yeah.
But what that is if, again, you have here where the two bones would be, and then the disc used to be here, we go in from the front, make a small incision, and I remove that disc. Take out the disc, clean off the spinal cord and nerves, and then when that's done, you've decompressed the spine and nerves. You've done what really the patient needs, but you can't leave it that way. We have to rebuild it with something. The most traditional approach to that, and what most people are candidates for, is the fusion, where we put in a spacer, usually made of titanium, and then a plate over the front that holds it in place. But over the recent years, what we've talked about more and more, or what are ways that we can treat these patients without having to do a fusion? Is there a different way? Is there a better way? And so that's where the whole idea of motion preservation, where we still can put something in there, but that maintains motion. And so that's where this disc replacement has come up, and it really has gained popularity recently. You know, we're just now getting some studies out over the past decade or so, so we're getting better data to know which patients is it right for.
That's cool.
And so if a patient comes in and they've got alignment issues or a bad slip, they're probably a better candidate for the fusion. But some people, if they're younger especially, and they just have an issue with the disc, then that's where we could talk about, you know, you may just need a discectomy, but if you need something more invasive, then you may be a good candidate for an artificial disc.
Okay. Yeah, and I love that you keep saying it's very individualized. You know.
Yeah, it's definitely not a cookie-cutter approach. Every patient's very different. And patients' expectations. Some patients, they just want it fixed. Some patients, they don't want any surgery, and that's totally understandable. You know, I'm always going to do the least invasive possible to help somebody.
Yeah.
And so the post-op recovery for an artificial disc versus a fusion is a little bit different. In a fusion, I might have you in a soft foam collar, you know, have you kind of avoid excessive movement for the first 6 to 8 weeks. Versus with the artificial disc, it's different. I want you moving, you know, no collar, you know, you can turn your head, you can move your head. There's not really much of a restriction at all.
Go ahead.
And I'm sure, you know, people are, this is a common enough thing that people are aware of it, of like, you know, you fuse one level, then you got to worry about the level above. And that's almost where I think an artificial disc is better, because the difference, to be honest, in like a one level fusion, most people aren't going to notice that decrease in range of motion. But what I like it for especially is it decreases the stress on the level above and below, so that may be something that we don't have to worry about as much.
Yeah, so this might be maybe you know, something that we move forward to in the future that might be even better for outcomes.
Possibly.
Yeah. Okay.
There's still more to know, but you know, I'm definitely becoming a believer in it.
Very cool. Okay. So is something like this, or you know, where you're having to have like you have these cervical issues or these neck issues, is this usually degenerative, like the SI joint, or maybe an injury?
So I see some injuries. Those usually come to me through the ER, and those cases are treated very different. If they need surgery, those are fusion procedures. But you know, 95+% of my practice is degenerative. You know, long-standing wear and tear. The disc loses integrity, loses strength, starts to bulge. And so just like the SI joint, people are always wanting to know, like, what did I do? Should I have not done this? Or I say, look, you probably didn't do anything to cause it.
Okay. So, you know, we've heard of slip discs or bulging discs. Are they, is that a similar phenomenon, or is slipping and bulging, is that different?
In my mind, they're about the same.
Okay.
You can make it really complicated, and you know, but when people colloquially say like a slip, a bulge, a protrusion, a herniation, it refers to the same thing, just different words.
Okay. And so it would either of these surgeries be considered like a major surgery, in your opinion?
No.
Okay.
No, but you know, surgery is surgery, right? You know, everything has risk, but the artificial disc, the SI joint replacement, reason I'm a big fan of it is because it, in my opinion, is a more minor surgery. It's outpatient. It's a quick recovery.
Outpatient. Wow.
Yeah. So I've seen a lot of people, you know, that were debilitated for a long time and so afraid to have surgery. You know, on those patients, we do something and their life truly is different and changed.
That's awesome.
And they're like, if I would have known it would have been like this, I wish I would have done it years ago.
Yeah. Yeah. And it just improves their quality of life so much.
Absolutely. Yeah. And they understand it's not going to be perfect, and they're like, look, but again, it goes back to quality of life and doing what they want to do.
Yeah, so the recovery for like a cervical, you said artificial disc or disc replacement, both of those procedures, I think you mentioned a fusion. What would the fusion, you mentioned that they have that foam, so, right, and you can't move for 6 to 8 weeks or so?
Yeah, I mean, it just depends. If I'm doing a fusion and it's a smaller fusion, maybe 1 or 2 levels, it's just a little supportive neck collar is all. And I'm like, you don't have to wear it all the time, but when you're up and moving around or sleeping, wear it for 6 weeks. Versus if it's a disc replacement, I'm not trying to immobilize anything because I'm not trying to make anything fuse in a position. So you don't need a collar, use common sense, but, kind of do what you need to do. You're still going to, have a sore throat and be kind of down for the first week or so, but yeah, it's a quicker recovery.
Gotcha. And is this something that you would use a robot for as well?
Not for this. No, it doesn't really have a role in this because it wouldn't really add a whole lot for this type of procedure, but it's still a small procedure. Usually for a 1 level, it's an incision about that long, and people have a sore throat. That's usually the main thing after surgery. Okay,
just because you're going around.
Right, having to move things over.
So you go from the front.
Exactly.
This way. Okay.
Yeah, go from the front.
Okay, so what are some things maybe that you would tell, let's say somebody's watching at home and they know that they might need this surgery and they're on the fence, and you've had testimonials where they wish they would have done it sooner. What would you tell someone that's on the fence about getting this surgery?
It depends where they are with their neurologic function. If they have weakness, if they have, like major issues and it's not pain, I would say, really need to get this done. But if it's, they've been dealing with it and it's hurting and they're on the fence, it's always one of those, come in, sit down, let's talk in person, let me print off your pictures, show you these models, let you hold it. And usually doing it in person, and patients kind of get a feel for if this is something they really want to do or not.
Yeah, using models like this, showing them what they're working with.
When patients understand what they're having done, it makes a huge difference.
Yeah, I agree, for sure. Because when you think about the spinal cord or anything to do with the spine, it's a little daunting, Yeah,
and I tell people, like, bring your family, bring your spouse, kids, write down questions beforehand, like, let's go through it all. I want everybody to leave, like, feeling 100% comfortable with whatever they're doing.
Right, and at the end of the day, as you mentioned, it is a decision that they make. It's,
it's a decision that we all make together. There's never pressure.
Awesome. And so remind me again of the conservative treatments that you also like to do, like the physical therapy and other things like that.
Physical therapy, stretching, anti-inflammatories, simple medications, and then the next step up from there would be usually to get injections into the neck, and I'd do that with pain management colleagues, do those for me.
Okay.
And usually people have already had most of that by the time they come to see me.
Okay.
But those are almost always great first steps to consider.
So even if they were referred by their physician and they wanted to start with the conservative treatment, you would be able to help them with
I facilitate that all the time.
Okay,
Yeah, and
great.
I watch them and we make sure that they're progressing the way that we both want.
And then you can follow them long term and say, if this progresses, we can then talk about that surgery option.
We usually leave the first visit with a very clear plan of, this is, the plan for the next year. We're going to do this. If this doesn't work, then we've got option B and C to follow.
Cool. Okay. So remind us where you're at, where you're located here in Shreveport-Bossier, and, if somebody wanted to, like a physician referral, where would they need to send that to?
So I work for Willis-Knighton Health System. My office is at Willis-Knighton Bossier campus.
Okay.
So it's the name of the practice is Precision Neurosurgery. But if they need to come see me or have any concerns, the regular doctor, anybody can just send a referral, and we'll get that processed and get them in.
So since this is like would you consider elective surgery?
Yes.
Okay, so would insurance cover this, or?
It should, but
Okay.
We run all that through the insurance first to make sure.
Okay, yeah, so all of that will be handled in
Exactly.
that first session. Okay, and so again, if you're interested in seeing Dr. Hefner, you need that physician referral, whether that's from, you said, the ER or a specialty clinic or your
Right.
PCP, your family doctor.
And all that really is just to help make sure that I'm the right person for that patient.
Yeah.
That I'm able to treat whatever they're coming in for.
Awesome.
Yep.
And then you'll set up an appointment with them and do an evaluation and go from there.
Yes, ma'am.
Sounds great. All right. Well, thanks for your time, doctor. And I learned a lot about all the things. So thanks again for joining us. And if you want to watch or rewatch today's episode, just head to our website at ktbs.com/Healthline 3. And unfortunately, that's all the time that we have for your Healthline 3 today. And thanks for joining us, and have a healthy and happy day.